Good afternoon, everyone, and on our guest from the West Coast, good morning. And my name is C.D. Mamaril, and on behalf of the Systems for Action National Program Office here at the University of Kentucky, we'd like to welcome everyone to today's webinar, our PHSR Research and Progress webinar, focusing on bridging health and healthcare. And we have an exciting topic that we will be having today, that is evaluating the impact of organizational partnerships on community resilience. And as a reminder to every presentation for today and
Overall, we've always referred to this part of the evaluation as partner. The Los Angeles County Community Disaster Resilience Project was a project in which community coalitions were brought together throughout LA to create new methods of strengthening communities and neighborhoods in the face of disasters. And I think at its root, the project really sought to find new ways that the Department of Public Health could engage communities and engage the community and give it a greater voice in preparedness. So today I'm going to talk a little bit about the definition of community resilience that we used and describe a little about how we use that to create our framework for this part of the evaluation. And then I'll also provide some more details about the overall project to kind of put the research in the appropriate context. And then I'll describe in greater detail what partner is and how it was used in these analyses. And then finally I'll go into our results and end with a few conclusions. This is work that was done by a number of people and that had contributions from a number of organizations. So the study team was myself, Anita Chandra at RAND, Asia Spears at RAND, has been working on this for a couple of years. David Eisenman, who will comment on the research a little bit later, was also involved in helping us develop the partner tool and has been working with us in the analysis process as well. The tool was created by Danielle Varda, and she and Sarah Sprong at the University of Colorado, Denver, are important contributors to the work as well. But it couldn't have been done first without all of the community partners that participated in the coalitions across the project. This is their data that they used to help them think about what they were going to do, and that we used to try to take a peek at how these kinds of relationships work. Organizationally, there was a number of partners in this work. Primarily, the Los Angeles County Department of Public Health was the sponsor of the project, led all of the work that was involved, and so it was a real pleasure to be able to work with that department to take a look at this particular look at the relationships that were being developed. And in addition, there were a number of partners that worked on the project throughout its implementation, including the UCLA, Emergency Network Los Angeles, which is the local VOAD, or Voluntary Organization Active in Disaster, Loma Linda University, and community partners. And this part of the research evaluation was funded by the Robert Wood Johnson Foundation, and I think that's why we're all here today. So I want to thank all of those organizations and people for their contributions. So the definition of community resilience, I know that RAND was not first in developing a definition, and in fact what we did was we, over a 2-year period, we engaged in some formative work to try to capture the definition of resilience that was percolating in a number of different sectors already. And we tried to develop that definition in the context of public health emergencies. So we reviewed literature in a lot of different fields, and we engaged in some qualitative work with not only experts in preparedness, but also community representatives that had a stake in preparedness and disaster resilience ideas, and community members that were also adversely affected by these types of events. And what we landed on was that resilience is not a state, like a steady state. It's a process, and it's one that really focuses on communities developing the capacity to account for their vulnerabilities and then develop the capacity to prevent or deal with an incident when it happens, recover effectively, and in a way that I think makes the community stronger, and then learn from a past event and apply those lessons to future events. Once we had kind of nailed down the definition based on all this work, we started thinking backwards about and looked at what other people were saying and what our informants were suggesting were the common or core components of community resilience. And what that led to was this figure, which shows that resilience, working backwards, really comes from the social and economic well-being and the physical and psychological health of the population, whether in a community there's effective risk communication, social connectedness for resource exchange, and for also for having community members have ownership over the process for developing resilience and a say in how that's developed in their community. So it's not just them connected to one another, but them connected to the governmental and non-governmental organizations that develop preparedness and resilience policies in communities. And working backwards from there, we found that there were a number of levers that one could address in order to work and develop resilience. And those levers include wellness, education about risks and resources that are available, engagement, which is really about engaging the community members in the process, self-sufficiency, which includes having communities have responsibility for preparedness. So not suggesting that other institutions don't have it, but that there is a role for community in preparedness. And then partnership, which is bringing together all of the organizations that contribute. In this work, we focus, in the work I'm presenting today, the evaluation focuses largely on the education, engagement, self-sufficiency, and partnerships. And the social network analysis is really mostly about the partnerships and the engagement piece of this kind of a framework. And there are other evaluation components that are ongoing that address other aspects of the overall project. And there's a number of websites that I'll refer to at the end of the study, at the end of the presentation, to show you where you can find greater information about what's going on. This next slide shows, I think, what I was trying to convey about the communities having a role in the preparedness world. And we didn't put public health at the center of this on purpose, but what this diagram really shows is that people are integrated in, or they're supported by, all of these different networks in their community. And in a disaster, an individual seeks support from all of these pieces. And at a minimum, they're interacting in these spaces, so that what community resilience does, I think, is it recognizes and incorporates this network into its framework, so that the emphasis isn't on the individual alone developing a kit or a plan, but on this network of organizations being prepared to address the overall needs of a community. And in our conception at the Los Angeles County Department of Health and in the project in particular, what we've been saying is that the emphasis changes from individual resilience, which is about emergency kits and plans and individual education and individual or household stockpiles and messages directed at the household, to community resilience, which involves assessing and addressing community vulnerabilities, not just individual gaps in knowledge or readiness, developing community partnerships to achieve that kind of an end, community training, education, engagement, so that the community is not just being told to do something that they're not used to, but are given resources to help make that connection and do that work, and then supporting community preparedness or networks or social connections to make sure that the network is prepared for the disaster, not just the individual. I think one of our respondents said it best in that early formative work when he said that, and it's that from his perspective as a pastor, that churches were really first responders, and the first responders, the place where people go for help and support in the immediate aftermath of a disaster. And I don't know that that kind of concept has always been captured. So moving on to kind of describe what the overall project was, I think we started with a 2-year development phase where or formative phase where we worked with, in this project, worked with communities across Los Angeles County, communities, stakeholders in the Department of Public Health and outside of the Department of Public Health, people with lots of experience and little experience in disaster preparedness, to try to figure out what would the project look like. How would you develop resilience and try to measure it in a large area like Los Angeles County. And so the result of that was a 3-year pilot in which we ultimately chose to work at the individual community level. So we chose 24 communities. Some of the characteristics of those communities were that they had, I think, on average about 35,000 people. They had to have a conception of a community, so some were neighborhoods in Los Angeles, large neighborhoods, and some were smaller cities in and around the city of Los Angeles. But they had to have a conception that they were part of that community, so they were part of Culver City or they're a part of Watts, and that it has an identity. And then they also had to have a network of organizations like educational organizations, nonprofit, community-based organizations that would be available to support the work of the coalition. And ultimately, they also had to have a coalition that was working on some aspect of health or public health or something that was willing to repurpose some of its efforts towards this idea of resilience or preparedness. And so once we identified 24 communities that looked like that in LA, we ultimately, through formative work, chose 16 to work with, and those 16 were then randomized into 2 arms. One was community resilience, and the other was preparedness. The emergency preparedness communities continued to focus on individual and family preparedness, and so where the community resilience ones were kind of the treatment arm of this overall project. And what we did was, in both communities, the project offered financial support of about $15,000 per year And then in the resilience communities, we developed a toolkit in partnership with all the stakeholders that did the formative work with us that illustrated how to do things like grow and support a coalition, how to engage in specific tasks like psychological first aid, working on things like mapping community resources, vulnerabilities, and assets. And then we also, throughout the project, did things like implement quality improvement tools, such as a tabletop exercise that walked each of these communities through how they would leverage their network during an event such as a heat wave or a measles outbreak. We did those tabletops actually in all of the communities, whereas the toolkit and the specific training and support went to the community resilience communities only. Each of those communities was, there was a nurse or another public health educator or expert staff person from the Department of Public Health that served as a facilitator in all 16 of the communities. The resilience communities all had public health nurses serving as those facilitators. And Sandra Gomez was a facilitator, and she'll be commenting on this work a little bit later after my part of the presentation. So the idea was to work with the resilience communities, provide resources to both, and observe and learn how these different types of coalitions start to work on preparedness and resilience activities in their communities. And so the role of this particular research project was to look at the development of the relationships within both of those types of coalitions and look at how they changed over time. And so what we did what we used to do that was something called PARTNER, which stands for Program to Analyze, Record, and Track Networks to Enhance Relationships. And PARTNER was created by Danielle Varda, who was formerly a researcher at RAND, and she developed at RAND with my research partner on this project, Anita Chandra. I think her and their vision was to get social and network analysis into the hands of users. So and based on the observation that people who use these data often learn something about the network that is useful for planning. And so typically, social network analysis is done in places like RAND or universities and not always with people who could really use that data. And I think that was Danielle's vision for this type of work. So typically the way PARTNER works is that an individual community, and many do this, will go to Danielle or to the PARTNER website and will use the tool to help develop and assess the relationships in their own community. So typically it's used by a single partnership, although I think in a growing way, researchers like us are starting to compare multiple coalitions over time. So typically the person who comes into it the administrator will collect the partner data, and we took on that role at RAND to take some of that onus off of the nurses that were doing a lot of, and the other facilitators that were doing a lot of their own work in the community. The way it works, though, is that Danielle has created a basic survey instrument that surveys the nature of the relationships in the coalition. It can be tailored, and we did tailor it to measure other aspects of those relationships as well as the activities that are ongoing in the coalitions and how the organizations are interacting around those activities. And so what will happen is that the administrator will identify all of the network partners and then send out the survey to those partners. It's usually done online, partners online for organizations that can handle that. But because we had such a diverse set of coalitions with people and organizations that had varying capacity to go online and complete a survey, we also offered in-person surveys. So we created an in-person version of the same tool, translated it into Spanish, and then some communities went out and did paper and pencil surveys in those communities, and then we ourselves put that data back into PARTNER, so it would all be on the online tool. And just to get a picture, while this shows what some of the data looks like, the network data, it also illustrates what's in part what's going on. You're measuring these different nodes. So who's in the network, how those organizations are connected, And although it's not represented here, you can look at the strength of the ties and information, I should say more information specifically about the ties between those organizations. So it really does measure a host of standard social network measures like the connectivity, the frequency of interactions, trust among partners, the value of partners to the mission of the organization. Characteristics of the individual organizations in the collaborative are also measured, such as how central each organization is to the network, the effective network size, how close each member is to one another, and whether there are duplications and links between organizations, and then and others like relative connectivity, which is based on measures of value and trust and the number of connections to others, and it indicates the level of benefit an organization receives as a network member in relation to the member with the highest level of benefit. So there's these standard measures of networks, but then, as I mentioned, what we also did was we asked them about a host of activities that they could have been engaged in, ranging from providing information to community members to tailoring information to specific populations that they thought might be vulnerable in their community to disasters, to engaging in some of the training activities based on trainings that we were provided, such as providing psychological first aid and a host of other activities. And then it also asks about how well or the degree to which the organizations in the network work together on those kinds of activities, and then some subjective questions about the value that they think their coalition receives from the activities that they're engaged in. It's been used in a variety of settings to measure things like improving substance abuse prevention, measuring relationships that change at the local and state level for one organization. Another organization used it to evaluate its ongoing development process. And then, as I think I mentioned, there's a quality improvement aspect to this that's also really important. And so just as we did in New Hampshire, one network of organizations looked at not only how their key stakeholders were connected to get a better understanding of how they work together to address health issues, but they also assessed what partnerships existed, how they could be strengthened, and then they started to work together to try to chart those relationships out to make improvements where that was possible. And we asked our coalitions to do the same kind of thing with the partner data, and I'll talk a little bit about that too. And the way it could be used is just simply asking people to look at the data and identify if there are ways that they could make changes. Ask who's at the table in their partnership. Are the right connections being made? Are the right partners engaged in the right activities to achieve the goals of the partnership? And so, as I said, we asked the coalitions to do that, and we work with the nurses to in the community resilience coalitions to engage in some of that type of work. To do that, we went through a multi-stage process of trying to figure out what's the best way to get this data into their hands. That started with working with a few individual nurses to review all of the data that we had, to creating a variety of different written products that would be useful for this exchange, and not just written, but also charts that really illustrate the partner data. And what we heard was that from the nurses' perspective, and so just to be honest, I would think we were sure that we were going to use the quality improvement aspect of this because we weren't sure how to get the data into the coalition's hands, and so we really wanted to make sure we went through the facilitators to be able to do that. And what we learned is that they thought that it really made a lot of sense to them in looking at that data, and looking back on it, they suggested that the coalition has changed since the survey was given and results were presented. And that they told us that they would be excited to see this. And so what we did was we created presentations for the communities that went out in multiple different ways. In some cases, RAND researchers went out to present the data. In other cases, we armed some additional technical assistance folks within the project to work with the coalition with their individual data. And so what that individual data looked like, there was a range, but we did things like present to them back the sectors that were participating in their coalition. And by sectors, I mean the 11 CDC sectors that they think are, that they suggested are important for community resilience. So we identified what sector each organization was in and then showed them where there were sectors that weren't yet participating in their coalition through products like this. We also looked at the type of activities that they were engaged in and worked through discussions with them about what activities they were engaged in, whether there were others that they wanted to be involved in, and which types of activities did they think their coalition received the most benefit. So they were learning from each other what their attitudes were about these different activities. And so on the next couple of slides, I just want to present some of our overall results. And I think we said, as I said, we emphasize the importance of growing these collaborations in the resilience communities. And, and it seems to have had an impact in a couple of different ways. In the first year, the resilience coalitions had slightly more members on average, and then that gap widened over the years so that the differences were significant by year 2. And I don't think I said it, I should have, but we measured partner at 2 points in time for these coalitions at the beginning as a baseline, and then a year later after they had a chance to start to work together. So the resilience coalitions had more members in year 1, and that grew to be a significant difference by year 2. And then in years 1 and 2, there was significantly more sectors represented in the resilience coalitions than in the preparedness coalitions. And that's just simply saying they had more partners, and they had more partners because we asked them to really grow their coalitions and gave them resources for doing that. Then the resilience coalitions, in year 1, trust was lower in these coalitions. It was significantly lower. But then by year 2, their trust in one another had increased so that that difference was no longer significant. And I think what this suggests is that in our rush to build these newer, bigger coalitions, we may have impacted the relationships negatively. So we threw a bunch of new partners together to start working on brand new tasks. And as they try to figure out what the tasks are and how to implement them, it really created a strain on the coalition. But then as they work together over time, perhaps they started to build trust in one another as they worked and achieved some of the goals of the coalition activities. In terms of activities, there's a lot here. There are some questions coming in, so let me pause and see if. So the one that came in was, has the church as the first responder been studied, or was the comment anecdotal? Yeah, that pastor participated in the formative work, and that church didn't and there was not a church from that pastor's church did not end up in one of the coalitions, so we didn't formally study it. So the activities that I wanted to point out a couple things. So this table presents the proportion of respondents in the proportion of coalitions that reported that they were engaged in these different activities. So these are all the activities where at least one coalition in year 1 or year 2 said that they were involved in, and we asked about a lot of other activities that nobody had engaged in. And so I'll give so this is for year 1, year 2 for the preparedness and resilience communities. And I'll give an overall, so you don't have to try to study every piece of this. I think overall what we saw was that the resilience communities typically had more of the coalitions reporting that they engaged in these different activities than the preparedness communities. So they were more active on all of these activities. But by year 2, both the resilience and the preparedness communities evolved so that there wasn't a strict difference in the number of activities that were being engaged in by the 2 different types of coalitions, but they evolved in, I think, different ways. And so I've bolded a couple things that I wanted to point out. In terms of the resilience communities, it looks like they engaged in more of the activities that we provided training for, and that may seem obvious, but having them actually report that back to us, I think, is important. So they did things that I think were just an outgrowth of having these varied participants in their community. So they did things like work with the media more often than the preparedness communities to communicate about their coalition's activities, and they also participated in community mapping. Sahana is the name of the tool that we created for them. And then they were more likely to have held psychological first aid training in their community than the preparedness communities. The preparedness communities, on the other hand, were more likely to report that they developed plans to communicate with residents during disasters, and that they exercised or implemented community disaster plans during emergencies. So my take on this is that it's that in both kinds of coalitions, when you support them, they're going to evolve in terms of the types of activities that they engage in. But an overarching organization like a Department of Public Health or other sponsor can impact what it is that those coalitions do by providing resources and training specifically targeted at those kinds of activities. But the way that the people in the organizations participated together on these activities was different in the two different arms of the study. So this presents our conception of the level of activity on any one individual activity. So in terms of activities, they could just be engaged in process type activities where they attend meetings together. That could increase to sharing information about an activity, and that's called cooperative. Coordinated activities involve both of those, but then they're also engaged in training ideas and developing interventions. And then finally, integrated activities are when they do all of that and then implement the trainings and activities together. And overall, what I think this picture is showing is that there was a difference by arm in sort of the mix of these activities, where the preparedness communities were more likely to engage in integrated activities than the resilience ones, but the resilience communities were more engaged in cooperative activities. And I think this is also a reflection of where we were in the project. We brought new partners together in the resilience communities, and so they spent a lot of time sharing information. But they also, I think it's possible that they could be engaged in activities in a different way, where the core group of organizations participating could change from when they're planning an activity to implementing it, because they have many more members and are engaged in different processes, whereas the preparedness communities are smaller and have a network that has been working together, and I think they kind of take an all-hands approach to the activities that they implement. I'm running out of time, so I'll just we did show them their network maps, and we talked to them about some of what the meanings of these were. So what we tried to do was show them for the most well-connected coalition, what did the organization look like in terms of their level of activity on these different types of conceptions of activities, and then where did the coalition itself fall relative to that, and that was just for questions about how they wanted to engage in their work. And then you can see over time that the networks themselves change, so the most well-connected coalition has changed, and so does the individual network itself. So it's a dynamic process as you move through these activities. So overall, I think that what we found was that there can be a lot, as in the Department of Public Health and other funders or organizations interested in kind of creating these networks can have an important impact on them. And you have to do it, I think, with some degree of caution. We saw in that first year that we may have impacted trust negatively by bringing together a lot of partners together quickly. We did learn that trust, that difference dissipated over time. And I think we also learned that the activities that they engage in look very differently. I think the jury's still out about because there are other evaluation aspects going on about what exactly do these differences in activities really mean. So there were variable response rates over time. So different people represented different coalitions, and different numbers of organizations participated in the survey. So again, under the caution about our results is that that these are really two different snapshots in time as opposed to tracking the same people longitudinally. And it was a short period of time, just a year. But the results are also dependent on how people interpret the question. So communication could be handing out flyers at a health fair, or it could be engaging in a process where you bring together multiple organizations to talk about what their role in a disaster is going to be. And so the organizations themselves may interpret that differently. And then what we think of as being something more like community resilience or less like community resilience as researchers could be different than what is being reported. And so we don't know if those activities are always more like community resilience or preparedness, but we do have plans to start to really look at, I think, in a more qualitative and in-depth way, all of the activities that we're engaged in all of these coalitions. We've collected a lot of different data that we can use for that purpose. And then I just want to point out that you can find a lot more information about this study and about the overall project at the LA Resilience website, which is listed first there. I think there's a mistake in that slide, so I'll make sure that's corrected before that goes out for you. And then RAND has its own community resilience website. And then some of the key written publications about the early part of the development of this project are listed here too, and that will all be available for you. So I'll pause there and I'll let the commentators, actually let me answer a question before we go to the commentators. The first is how were residents engaged in these actually, you know what? I think we had talked about this earlier. CB said that we'll get to the questions afterwards. So I want to make sure that David and Sandra have a chance to comment. So CB, I'll turn it over to you at this point.
Thank you, Malcolm. Yes. So we encourage everyone, even while the commentaries are being given, to start typing out your questions, because there is a lag for the questions to appear on the chat box, and that way we can get to them towards the end of the commentary. So with that, I'd like to first introduce our commentators, and then they'll be giving their commentaries one after the other. So our first commentator will be Dr. David Eisenman, who is an associate professor at the UCLA David Geffen School of Medicine and the UCLA Fielding School of Public Health, where he directs the Center for Public Health and Disasters. Dr. Eisenman is the Preparedness Science Officer for the Los Angeles County Department of Public Health, where he leads the Robert Wood Johnson Foundation funded evaluation of the Los Angeles County Community Disaster Resilience Project. Our second commentator will be Sandra Gomez, who is a public health nurse at the Los Angeles County Department of Public Health. Sandra's has over 20 years of nursing experience, with which she's been committed to the physical and mental well-being of individuals, families, and communities. Sandra has practiced in hospital, primary care, community health services, and case management settings. She has worked in LA County since 1990, starting at the LA CUSC Medical Center, then to Olive View Medical Center and the Ambulatory Care Network, and currently for Department of Public Health. Since 2011, Sandra has been serving the role of an emergency preparedness public health nurse, performing duties as they relate to the Los Angeles County Community Disaster Resilience activities, including a major role in the Emergency Preparedness Public Health Nursing Program, which promotes the capacity of Los Angeles County residents to respond to and recover from the effects of natural disasters, bioterrorism, and emerging infectious diseases. So with that, I want to turn it over to our first commentator, David. Go ahead.
All right, thank you. I'll assume everybody can hear me, is that right?
Correct. You're loud and clear. Go ahead.
So, Malcolm, that was a fantastic presentation. I always learn from you, even when I've been working with you for several years. Thank you. You know, it is, I think, important to also situate the work that Malcolm discussed inside the larger context of CR, community resilience programs nationally and globally, and their evaluation or lack of evaluation. You know, Malcolm started off with a definition of community resilience. The field has struggled with that for a long time, and in some ways, that conversation has led to a lot of challenges in measurement as a result. Now, it's known that community resilience is difficult to measure, as Malcolm alluded to, but that didn't really stop Malcolm and the project from evaluating the project, which is an essential function of any public health intervention. Now, This led to creative considerations of what would be proxy measures of community resilience. And looking back at the theoretical model, taking a look at what we were going to focus on, using a logic model approach, and saying how can we evaluate this one lever, which is organizational networks. The partner tool became an obvious choice, and Malcolm led that. And that's really the kind of creative thinking we should be applying to other areas in public health. So in that way, this initiative and Malcolm's evaluation approach is an example that gives really a lesson for influencing the development of the whole field of community resilience. There are programs across the nation in many cities being funded by many federal foundations as well as nonprofit foundations. Many of them are going without evaluation, and this just shows that it really can be done. Malcolm's raised some questions for me. Really, what I started to think about when I saw the results again is what is the key ingredient that we think in organizational partnerships is going to increase resilience? Is it trust? Is it joint activities? Is it having meaningful collaborations? What does that mean? So, what is the key ingredient? And I'd like to build, I don't think that this work can drill down to that, but I think that it raises that question. Malcolm raised that question. We saw improvements in trust. We saw a diversity of activities in the CR arm consistent with our intention. But on the other hand, we saw that the preparedness arm had a higher level of integration at the end. So what really do we think matters in terms of resilience? And that's an open question for the field. Lastly, I love this kind of work. It's really fascinating. It also raises to me a communications quandary, which is, if we want to improve community resilience, we will need markers, or do we need markers, that are going to capture and hold the attention of the policymakers and of the practitioners and of the community, and what are they? So with that, I will stop. Thank you.
Thank you, David. Sandra, you have, I'll turn it over to you for your comment.
Oh, yes, thank you. I just want to say that the emergency public health nurses, it's 8 of us that did the resiliency portion of the project. And as facilitators for the community resilience groups, we identified areas of need that was, as a nursing term, a knowledge deficit regarding the concept of community resilience within the communities that we worked with. So we all did get together and we've talked about what or how are we going to address when we first started the project. So we did continue using our public health nursing practice model that we use. We did continuously assess and diagnose and identified outcomes plans. We implemented and evaluated the resiliency community coalitions throughout the entire process. And as EPPHNs, or Emergency Preparedness Public Health Nurses, we provided input in strategic planning, toolkits, construction, output interventions, as Malcolm earlier stated, that we also worked in data gathering, and also the project provided us with data and also different types of tools that we could use with the communities. So we, as EPPHNs, we took an active role in community resiliency activities by assuming various roles as needed within the community while we were in the community. For example, I continued to be a public health nurse. In one coalition, they wanted to practice trying to provide some medical help with their community, so we rolled out an immunization flu outreach, and we provided the flu vaccines, but they organized everything in this coalition. That was the La Crescenta Coalition. They call themselves CV Ready. So we worked with partnership. They worked with the library. They brought in the library. They brought in public health. So they used a lot of the sectors that Malcolm stated earlier about how we helped them understand that they needed sectors. They needed different uh, organizations in their communities to activate some kind of activity, whether it be practice activity or a true emergency um, activity, that they needed to have different partnerships within the community. That was the I believe the core of this project, to get them going, to understand that they cannot do it by themselves in an emergency, or to understand what community resiliency was, and hopefully they can recover quicker. So we encourage several pre-existing institutional and sometimes culture. We also experience some cultural hurdles in the process of building community resiliency with our communities. And we also, the consensus as EPPHNs was that a community deficit regarding the concept of community resistance was real. And what we learned from the actual coalitions, that to gain improvement and to gain motivation and trust, we really needed to be there not just one time, but the 3 years that we were with them, we developed this trust as nurses. We developed motivation within the coalition. So we saw this, well, actually I'm seeing this motivation even now currently with the CV Ready Coalition. They actually just this month did their own tabletop with all the tools that we gave them. They led the tabletop, not a partner agency, not not the experts, but they themselves became, in my eyes, experts. They brought in and invited all the different sectors, and we already sunsetted the project in June, and they're continually doing this. So that's an exciting thing for me as a facilitator to be part of, and I continue to meet with them quarterly. So they've developed also a formal board and board members to guide their activities in the future. They plan to implement Neighborhood Watch and introduce the LACCDR toolkit that was developed within their Neighborhood Watches. And they already started doing CPR classes and first aid within the Neighborhood Watch, and introduced also the CERT, the Community Emergency Response Training. So they really have ambitious dreams, but they're actually doing it. And that's what actually keeps me excited with this project. And as emergency preparedness public health nurses, we also recognize that the community resiliencies cannot be achieved without continuous communication and education and ongoing partnership with these groups. And thank you so much for allowing me to share my experiences with you. And with that, I conclude my comment. Thank you.
Thank you, Sandra. And before we go to the questions, actually, we want to give Malcolm another opportunity to respond to the comments, or anything that you also wanted to add it on to your presentation too as well, Malcolm?
Oh, sure. So, David, I thought you raised the most important question. What's the key ingredient that develops resilience? And you're right. This research, I don't think can answer that. It may point in some directions. I think, for me, the start of the answer to that is sustainability, and I think Sandra's comments really touch on that too. To what degree are the coalitions going to continue these not just the coalitions in the department, going to continue this relationship and these activities past this project? So this was the I'll put it in quotes, the experimental version of it, but these types of activities and these types of relationships could be rolled out on a much larger scale across Los Angeles, or other communities. So if you look a year from now or 5 years from now, to what degree has the culture at DPH changed, and then how does that result in terms of developing relationships with communities towards these activities, and then are the activities different? And do they build something that we would call resilience? I think that's the way that you measure the overall impact, and what you would want to bring to other coalitions over time. And then, Sandra, I think you were absolutely right about about the importance of the roles of the nurses, and it really made me reflect on that sustainability piece. I think that this shouldn't be designed as a we'll drop this product into a community and then have them just run it. I think the real culture change, and I think the real courage of the LA County Department of Public Health was really engaging communities in a process to develop this work, and then hopefully looking for ways to sustain it beyond the project. And the reason that's so valuable is because of the really hard work of the nurses to work with the coalitions on an ongoing basis to figure out what their needs were and how do you get resources to them to activate those needs. And you could see how successful Sandra was in particular in having a coalition that is doing their own tabletop. I hadn't heard that, and I think that's fantastic.
That just happened recently.
There were some other questions that came in that I think are really good ones.
Yeah. So what we'll do is feel free to answer, Malcolm, and we're also welcome to, you can also address the questions to the commentators. Commentators are also free to also chime in too as well. So would you want to just read them yourselves, Malcolm, and then just address them as they appear? So we have a few minutes to have some questions and discussions. So that's good.
Sure. It looks like there's, I think, two there. So one was, how are the residents engaged in these coalitions, and how is it different in the preparedness and the resilience communities? And David and Sandra could chime in here too. But the individual residents did participate in a number of the coalitions, and that was a challenge for our measurement. You didn't ask that piece, but when you think about an organizational survey and then you have individuals that are participating on their own behalf, we called them. We ended up doing is assigning them to the sector of community leadership, and they did come out in various ways across the communities. I don't think that I would have to go back and look at the number of individuals in each coalition and then compare in the resilience and preparedness communities to answer specifically your question. But I think I did want to note that they were there, and they were often important parts of the coalition because they brought either experience as longtime volunteers or as residents in that community to offer the context for how you do that work. And so they were welcomed and encouraged and often participated in different coalitions. Sandra or David, did you have anything to add about individuals participating in the coalitions?
Yes, like in the two coalitions that I work with, there was two different cities. Acton and Agua Dulce was one of them, and La Crescenta was another city. And so they each had unique individuals who participated. In La Crescenta, it started with the Fire Safe Council members, and from there they invited, once we did bring in education on how different sectors will help their mission, they started inviting other sector leads and also community members as well that were part of either husbands or wives. They all came in with the coalitions and participated, and that's how it grew. And like in Acton and Agua Dulce, they already had a large community emergency response training group, the CERT training group, and different sectors of the community that were involved in emergency preparedness. And from there it grew, where they invited, for example, in Acton and Agua Dulce, we presented psychological first aid, and they became excited about it. So they invited the mental health agency to come and run that part of their coalition program. So that in that way, the coalition core members invited other agencies on board or other sectors on board. Hello?
Yeah. David, did you have anything to add?
I might only add that we didn't, unfortunately, collect data that would answer that with an empirical answer of how the community was engaged in the coalition in different ways. We do know that the coalitions reached out somewhere along the line. Over 30,000 people in Los Angeles participated in an activity done by the 16 coalitions, and they were pretty much evenly distributed between the two arms.
Right, and David's pointing out something too, that another way to answer that question, which is that so the coalitions had participants that that were individual community members. That's where I started. That were helped lead the coalition activities. But then there was the outreach that the coalitions provided to individual residents, and so they created activities and trainings that individual community members could participate in. So there are now people who are trained in psychological first aid or CERT or CPR. In these communities that the coalitions were engaged in, and I think that the only thing I would add to that is that the notion of individual engagement looked different in different kinds of communities. So in Pico Union, which is a largely lower income Latino community near downtown Los Angeles, there was a history of individual activism, and so especially early in the coalition's development, you saw lots of individuals coming out to participate and add their voice to that process, and that continued throughout that coalition's existence. And another place that grew was in Palms, which is a sort of a neighborhood in West Los Angeles that has lots of diversity, but it is inhabited in large part by people who are living in apartment buildings. And the challenges and concerns that they had as apartment residents in Los Angeles brought several of them to the table to give the context of what the concerns are on a daily basis in a place like Palms, and then during an emergency, what those concerns would be. So it played out differently in those different communities. The next question was from Linda, who asked whether there were measures of political and socioeconomic status of the communities relative to the results. And then you added that more specifically a West Coast mentality versus a Midwest mentality. So I can't answer the second one. We weren't engaged in anywhere else other than Los Angeles. But I think, as I just alluded to, we had very different communities across Los Angeles. Some were more affluent, and some were closer to the beach. Some were in the mountains. Some were in the desert. Some were close to really high industrial areas. Some experienced different levels of disaster, including a fire at the port in Wilmington and wildfires, et cetera. And traumatic events occurred in some communities. We had some communities that you've heard of, and some that you haven't. Watts and Compton were both in this in the study, as well as Pico Union, and Hollywood was involved as well. So and it's true that they all have very different socioeconomic contexts, and we did that on purpose. So that variability, that diversity, was done on purpose so that we could capture the range of communities in Los Angeles. Some of that is generalizable to other communities. And some of it is not, because of our context of disasters and the mix of different people in Los Angeles. But the root of your question was, did we measure it and look at whether that diversity had an impact on the outcomes? And we can develop measures of that socioeconomic status, at least, and other aspects of diversity. But we have really a small number of coalitions, and so it would be really difficult to draw conclusions based on an analysis like that. All I can say is that it was really designed to capture that diversity. Sandra or David, do you want to comment on that aspect of it?
Can you hear me?
Yes, go ahead, Sandra. I think we have just a few minutes for last comment, and as the webinar is scheduled to end soon. But go ahead.
Oh, sorry, because I was unmuted. I was muted, so sorry.
No problem. Go ahead.
Malcolm, can you repeat the question or the comment?
They were asking whether we measured the political and socioeconomic status of the communities and whether that impacted the results.
Right. We did. To my knowledge, I mean, the two coalitions that I worked with, they were very affluent, both of them, in their differences. But there were differences that one was very rural area, and the mindset of acting in Agua Dulce when we first initiated the project was like I would say let me just say, a cowboy mindset, where their way of protecting themselves is with just guns. And that was quoted by, I'm quoting the coalition members, like that's how they thought about preparedness. And when we came in, we had to try to get them involved in different sectors and get them involved thinking in resiliency concept. And they feel that in Acton Awadul said they're very well prepared because they are rural and they do have extra supplies. They were thinking more of a preparedness, an individual preparedness, and not a whole community approach. And it might not be social economics, but I think it plays a lot into where you're living, whether it's by the beach, in the mountains, or in the desert. You have different types of hazards that you need to think about, and also bring in different sectors in the community. And that's my comment. Thank you.
Thank you, Sandra. So, we're running a little over, but Malcolm, we just want to ask last questions, just a quick, what are sort of the next steps with this project? And we'll end it at there. So please just share with us a little if you don't mind.
We have a number of evaluation components that are being wrapped up, and so like as Sandra said, the project itself has ended, but the activities, the coalitions live on, and the activities that they're engaged in continue to go on in some very exciting ways. And then on the research side, we're wrapping up evaluation on a number of fronts, including looking at the potential impact of residents outside of the participants, but the residents of the communities that had these different types of coalitions using survey data from the county. We have published results of the first tabletop and are in the process of publishing results of the second tabletop exercise that we conducted. These results are being finalized in a manuscript that will be published, and we are also engaged in thinking about how to draw more lessons learned from all of the data that we collected. So how do you get at that question that I raised, which was, how do you know that there's a difference in the type of activity that's occurring? And you really have to look at the activity logs and sort of the on the ground notes of each activity to be able to do that. And so those are the kinds of activities that we're engaged in right now to draw out those lessons.
All right, fantastic work and fantastic presentation. Thank you so much, Malcolm, and also thank you to our commentators too as well, David and Sandra. And we just want to remind everyone that today's webinar presentation is also available for download, or will be made available for download at our website. And also, we would like to invite everyone to as well, and to our other upcoming webinars, especially for next week in November 19. We have a good example of a pragmatic RCT project that will be presented, and we just look forward to seeing you, and visit our website too as well. And we want to again thank our presenters and our commentators and everyone for joining us for today's webinar, and we wish you all a very good day. Thank you very much.